Hello and welcome to today's Center for Healthcare Strategies webinar on facilitating cross-system data sharing for psychotropic medication oversight and monitoring, part of the Psychotropic Medications Virtual Learning Community webinar series. To eliminate background noise, phone lines are being muted during today's presentation. Question and answer sessions will be held after each presentation, and instructions for participation are shown on the screen at this time. If you experience technical difficulties today, you may dial 1-866-229-3239 for assistance. Today's event will be recorded and the slides will be sent to all participants after the webinar. At the completion of the webinar, we ask that you complete a very brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you are able to complete the survey. I will now turn the webinar over to Kemla Allen, Director of Child Health Quality at the Center for Healthcare Strategies.
Thank you, Travis, and welcome everyone to today's webinar. We want to first give thanks to the Annie E. Casey Foundation, who's supporting this work through a grant to the Center for Healthcare Strategies, and that grant is supporting a 6-state collaborative that is focused on improving oversight and monitoring of psychotropic medication use for children and youth in foster care. In addition to the intensive technical assistance being provided to those 6 states, the support from the Casey Foundation is also enabling us to extend participation in these webinars to 47 states through our virtual learning community and to states participating in the CHIPRA Quality Demonstration Grant. So thank you to our funders for that support. Today we are going to be talking about a topic that has been a challenge for a number of states and continues to be one of the things that prevents the effective oversight and monitoring of psychotropic medication use. I want to start by talking a little bit about the complex needs. I'm sorry, Travis, I should do that, right? The agenda? Sorry, I'm going to step back for a moment and just go quickly through the agenda for the call. This is our own quality improvement, and so just to give folks a sense of where we're going on today's call, we're going to start with some very brief comments that I'll do that'll provide a context for today's call. Then we'll move to 2 state presentations, one from our colleagues in Rhode Island, and they're going to be talking about how they've embarked upon a successful data sharing effort with their state Medicaid managed care program. And then we'll move to our colleagues in Oregon, Ted Williams, who will be sharing with us how they are using data to enable their key constituencies, including their providers, to better understand the use of psychotropic medication use among the foster care population. We will have several question and answer periods during today's webinar, and any questions that we're unable to get to during the course of the call, we will post online along with the other webinar materials. Thank you, Travis. So now, I want to talk a little bit for context-setting purposes about the needs of the children in foster care. So these are a population of children that are served by multiple systems. When we look at the engagement of children in foster care with systems other than the child welfare system, estimates range from 50 to 75% of those children also being in need of mental health services. 30 to 40% of them also being recipients of special education services, and between approximately 10 and 30% being involved in the juvenile justice system. We know recent federal legislation requires collaboration between the child welfare and Medicaid systems to meet the health-related needs of children in foster care, and a recent CHCS study underscores the importance of that collaboration, with us recognizing that both in terms of their service use and their expenditures, they are a high-need population. When we compare their utilization and expenditures to those of children who are on SSI, the dollars that are being allocated to children in foster care are 80% of those that are allocated to the SSI population. So I think we're really very clear that this is a population of children who have serious and complex health-related needs across multiple domains. And I should just state that when we talk about total Medicaid expenditures, that's both physical and behavioral health services. So I just want to make sure that that's clear. And to the last point here, oversight and monitoring of psychotropic medications requires access to data in multiple systems, because there are multiple systems that are paying for services being provided to this population. Next slide, please, Travis. Thank you. So when we think about what some of the challenges are to data sharing across agencies that are jointly serving this population, we see that there are a number of federal as well as state legislation and regulations that preclude or some of that data sharing. The intent of all of these is really to protect the child and family. Certainly, the challenges it presents to data sharing is an unintended consequence. So we don't want to in any way suggest that these are not important considerations. So each system has its own set of privacy regulations, and the challenge in sometimes being able to overcome these or figure out what is actually real and perceived or versus perceived is one that takes a lot of time and effort. And oftentimes the needs of the children and other priorities across those systems prevent there getting to be a resolution to that. So we know that that's something that's an ongoing concern. Next slide, please. In addition to the privacy issues, there are issues related to the level at which the data is available. So what we've seen is that the data we have may not give us the level of oversight ability that we need or we desire. And sometimes those systems that have the data, that there are inabilities to get those systems to interface. So there's different technological capacities across agencies. In some systems, the Medicaid system is advanced and the child welfare system is not yet quite at that level because of the funding that's available for the enhancements to information technology in the child welfare system. As I suggested, sometimes systems are not able to talk to each other at all. There's also a significant amount of time and effort that is required to upgrade or modify data systems, and certainly that is not at a minimal cost. So for some period of time, when those upgrades are taking place, those modifications are taking place, states have to run two systems at the same time, which is also, as we can all imagine, a challenge as well. One of the other issues that we find states are pressed by is the accuracy of data in other systems. So in each of our own systems, we have some sense of who's inputting the data, how reliable that data is. When we start to think about the data in other systems, we may not have visibility to those same parameters, and that can influence the ability to trust whether the data in those other systems is accurate. And then finally, establishing policies and protocol. If you overcome all of the hurdles that I just mentioned, there have to be policies and protocol in place that respect the regulations and that reflect the workflow across multiple agencies. So this is no small undertaking. Next slide, please. So with that as context, we want to turn to our next set of speakers, and I'm going to turn to Regine to do the introductions.
Thank you, Kamala, and thank you, presenters, for participating in today's webinar. We have presenters from Rhode Island who will be speaking about the state's approach to leverage the data capacity of their managed care organization, Neighborhood Health Plan, and our presenter from Oregon who will describe how the state is populating and using data dashboards to help providers and caseworkers improve the monitoring of psychotropic medications among foster children in their care. Our first presenters are Dr. Colleen Karen and Mr. Leon Saunders from the Rhode Island Department of Children, Youth, and Families. Since 2005, Dr. Karen is the Director of Data and Evaluation. She's also the Assistant Clinical Research Faculty Member at Brown University School of Public Health Epidemiology Department since 2000. From 96 to 01, Dr. Karen conducted public health research focusing on vulnerable families in urban areas, their social welfare, and their public health outcomes. She has experience in theory-based health behavior change, research design, program planning, and evaluation methods. Previously, she served as the U.S. Children's Bureau Child and Family Service Review Consultant, and Dr. Karen also received a PhD in public health from Temple University. And Mr. Saunders is the Implementation Director for Policy and Programs, where his responsibilities include the development and implementation of policy and programs to improve the efficiency of all areas of the department. Working within the Data and Evaluation Unit, Mr. Saunders facilitates the collection and analysis of internal and external data for program evaluation. And prior to joining the Data Evaluation Unit, Mr. Saunders was the IT manager for the department for over 10 years. Mr. Saunders has a master's degree in public administration from the University of Rhode Island. I'll now turn the presentation over to Dr. Colleen Karen and Mr. Leon Saunders.
Thank you. This is Colleen, and I'll be presenting the first portion of Rhode Island's presentation. Next slide, please. So the objectives for today will be understanding the data sharing relationship between the Rhode Island Department of Children, Youth, and Families and Neighborhood Health Plan, our managed Medicaid insurer, knowing the data planning process, understanding what guided the data elements, and knowing the use and limitations of the data. Next slide, please. DCYF supports and provides services to approximately 3,700 children ages 0 to 18 at any point in time. Approximately 1,700 are in foster care or in out-of-home placement, and approximately 2,000 are in-home. Our population includes child welfare, behavioral health, and juvenile justice. Next slide, please. Approximately 98% of children and youth in DCYF foster care are enrolled in the Neighborhood Health Plan, which is our state-managed Medicaid insurer. And NHP collects and manages behavioral health and medical service data. Prior to Rhode Island's participation in the Psychotropic Medication Initiative, DCYF had a data sharing agreement with Neighborhood Health Plan, wherein we received NHP data that populated the medical window in the Rhode Island statewide automated child welfare information system, our SACWIS system, which allowed for individual health-related information for DCYF caseworkers to view, information such as behavioral health services, medical services, diagnosis. It also then allowed us to then pull that data and aggregate that data and look at trends in terms of behavioral health services and diagnosis. Next slide, please. After Rhode Island's involvement in the Psychotropic Initiative, we increased our efforts to gain greater understanding of psychotropic medication utilization. And so prior to meeting with NHP, our Psychotropic Initiative work group met to discuss what were the questions that we wanted this data to answer. And we used the red flag system from the Psychotropic Initiative to guide some of those questions. And so we identified objectives for data on an individual and aggregate level and said, what are the clinical objective questions we want this data to answer? And what are some of the aggregate or the surveillance and outcome research questions that we want this data to answer? We also wanted to we also discussed and made sure that we wanted to receive the data on an individual level, because that was our unit of analysis, and it would allow us to then merge our data from NHP with our SACWIS data to look at longitudinal outcomes. Next slide, please. So in meeting with our neighborhood health plan, we not only brought the data elements we thought we might need, because it's not our data set and we don't know the data elements that may best answer our questions. We included what our purpose was for requesting the data along with the data elements we thought would answer those questions. So we provided them with a background of wanting data on the aggregate level so that we could answer questions such as just general surveillance, that we would be merging the data with our administrative data so that we can aggregate that and look at outcomes over time and trends, and that we can answer research questions such as evaluate programs, evaluate psychotropic medication and its interaction with some of the programs the children use and receive. We also wanted to emphasize that we would be using the data for the individual level, wherein we would be able to monitor the psychotropic medication appropriateness, clinical oversight, and management. Next slide, please. We also wanted to discuss with NHP the importance of having the individual level data for the DCYF population, because it will allow us to look at longitudinal data as well as provide for maximal manipulation of the data. And in this manner, it was in their best interest as well, because some of our questions may change over time, and this way we would not have to keep going back and requesting new information if we received it at the aggregate level. We also wanted to obtain aggregate level data on the non-DCYF population to look at relative comparisons so that if we're seeing changes in psychotropic utilization among the DCYF population, what was going on in larger context in terms of the general Medicaid managed population, and where we're seeing similar trends on those data elements and factors as well. We also met and included our child psychiatrist who is on the initiative so that she could review the medications that Neighborhood Health Plan had classified as psychotropic to see if that agreed with her and also met our needs for the psychotropic initiative. Next slide, please. The time it took to receive the NHP data was approximately 8 to 10 months after we had met with them and made all the decisions about which data elements would answer our questions, both on the clinical and the aggregate level. And there was a couple of iterations because the first data set that we received from them actually showed us a population of less than 700 than what we actually had. So there was a couple of iterations going back and forth with that. We also specified that we wanted the data format as a comma separated value, to receive the data on a quarterly basis, and to have summative data, and we would be analyzing the data using SAS. Next slide, please. So looking deeper into some of the principles and questions guiding the selection of data elements, again, we were influenced by the too young, too many, too long, and too much that would support our red flag system. But we also wanted to ask questions along the lines of what is the prevalence of psychotropic medication prescribed, what is the prevalence of receiving behavioral health service, and then relative, what is the prevalence of psychotropic medication in NHP non-DCYF data. Taking those last three bullets and looking at them a little bit further will be over the next few slides. Next slide, please. So what is the prevalence of psychotropic medication prescribed? So looking at it by age groups, less than 6, greater than or equal to 6 were some of our questions. And so that drove some of the data elements that we selected. By concurrent use, 1, 2, 3, 4 or more. By concurrent use by age groups. The most frequently prescribed medication out of all of our DCYF foster care population, and then out of those who are prescribed 1 or more medications. So the denominator would change in both of those. By medication class, out of all of our DCYF foster care population, and then also out of those who are prescribed at least 1 or more psychotropic medication. By medication class by age groups, and then by medication class by age groups among youth who are prescribed 1 or more psychotropic medication. Next slide, please. What is the prevalence of psychotropic medication prescribed by behavioral health services received? And then excluding attention deficit hyperactivity disorder or other potential non-psychiatric medications, because our child psychiatrists wanted to compare whether some psychotropic medications may not necessarily warrant behavioral health services. So when we're trying to look at the relationship between psychotropic medication utilization and the receipt of behavioral health services, we wanted to exclude some of the medications that may distort that relationship. By 1 behavioral health diagnosis or by 2 or more behavioral health diagnoses. Next slide, please. What is the prevalence of psychotropic medication prescribed by behavioral health hospitalizations, by behavioral health rehospitalization, and by time to rehospitalization? So these questions, again, were driving the data elements and how deep we needed to go with the data elements. So in the fact that we were looking at time to rehospitalization, we needed to have dates along with that and not just a flag for hospitalization or not. Next slide, please. Referring to bullet number 2, when we were digging in deeper, what is the presence of receiving a behavioral health service? By psychotropic medication of 1 or more, or by an absence of psychotropic medication. And we wanted to really look at the relationship between psychotropic medication and behavioral health services. As Rhode Island is implementing a system of care, we're really trying to increase the number of our community-based, evidence-based programs, and so we wanted to monitor the relationship as those programs increase, what is occurring with our psychotropic medication utilization. Next slide, please. Specific to looking at the DCYF population, foster care, and relative to the larger context, we will be comparing the prevalence of DCYF foster care population and the non-DCYF population by psychotropic medication utilization, by behavioral health service utilization, and psychiatric hospitalization utilization, because these will allow us to see what is going on in the larger context and perhaps what is related to some of our initiatives and what is related to just what's generally going on in the larger context. Next slide, please. Some of our questions also were involving how we would be linking this to our SACWIS data and looking at more longitudinal outcomes. So we were looking at what is the relationship between psychotropic medication and time in foster care, or time in congregate care, with re-entries to foster care, with level of care while in foster care, with maltreatment, and with the child adolescent needs and stress assessment that the department implements across all children who are in congregate care or in specialized foster care. Next slide, please. We also wanted to look at factors that would be predicting psychotropic medication. So that also drove some of the data elements that we were requesting from our neighborhood health partner plan. So what factors predict prescribed concurrent psychotropic medication? What factors predict prescribed psychotropic medication among children under 6? And what factors predict prescribed psychotropic medication duration? And part of the reason for this is that if we can identify factors that are associated with that, we can then implement an early warning system. We have done that with our children who are at risk for long-term foster care. So as soon as they enter into foster care, they are flagged if they fit a profile that puts them at risk, and then we can monitor them more closely. And something similar with the psychotropic medication we could also explore. Next slide, please. Using data to inform practice, policy, procedures, and evaluation. With the psychotropic medication utilization data, we aggregate it, and we have quite a few data venues to which to share. One is our senior team meeting, which meets on a weekly basis, and so on a regular basis we can share that information with our senior team, where our administrators for child welfare, behavioral health, and juvenile justice are present and can take that information and use it in the programs and practice with their providers as well as their workers. We have monthly data analytic meetings that include DCYF staff as well as our external stakeholders. There's a monthly child welfare advisory committee that includes internal and external stakeholders that the data is shared, and then publications, reports, and on our website. Next slide, please.
So this is Leon Saunders. Rhode Island has an existing consent process. The Child Welfare Regional Director will generally provide the final psychotropic medication authorization in cases where the child or the youth has been TPR'd, or when the parents are unavailable or unable to provide that consent. In addition, we may also have our juvenile corrections or child protective services administrators also provide that consent if necessary. Until this month, however, these administrators did not have access to a medical professional for any type of consultation on the request and relied primarily on the recommendations of the prescribing doctor or clinician when determining whether to approve or deny that request for medication. As of January 1st, we now have a child psychiatrist available for consultation on a limited basis. Therefore, all new requests for authorization will have the ability to be reviewed and tracked by a medical professional. Since the consultation time is limited, we are working to establish guidelines for requests that can be approved without consultation and those requests that should require consultation. An example of a request that we might determine does not require a consultation would be a youth who is only receiving a single medication for ADHD. As we increase the staffing in the new medical office, we do hope to provide medical review on all psychotropic medication requests. So now that we have a process in place to monitor new requests for psychotropic medication, we want to establish a process to go back and review requests that had been approved prior to January 1st. This is where we'll be using the NHP individual data. Since we received that data on an individual level, we'll go back to the most recent quarterly file that we've received, and we'll apply the red flags that Colleen mentioned earlier to prioritize those cases that we feel should be reviewed by the child psychiatrist. Next slide. So the flags we're using are too many, too young, too much, and too long. On too many, using the quarterly data, we'll identify any youth who is receiving more than one psychotropic medication from the same class, or any youth who is receiving 3 or more psychotropic medications. For too young, we will look at any child under the age of 6 who is receiving a psychotropic medication. For too much, the data we currently receive from NHP does not allow us to determine the dosage that the child is receiving. We have requested that NHP modify the report so that that information could be obtained in the future. Then finally, too long. The file we receive contains 3 months of data, so looking at how long a child has been on a psychotropic medication will require us to put several of those quarterly files together. Given our staffing limitations at this time, we've decided to focus our efforts on the too many and too young categories, and as our staffing increases, we'll reconsider adding this group to that review process. Next slide, please. Based upon the data that we received in calendar year 2012, the annual number of cases requiring review based upon that data is 159. That includes 115 youth who are on 3 or more psychotropic medications, as well as 44 children under the age of 6 who are on 1 or more psychotropic medications. Next slide, please. There are some limitations with the data that we're receiving. Within the NHP data set, they do not have an indicator for foster care. We're using a group code that NHP uses to classify youth. The group code that they're extracting from their system identifies youth who are in foster care. However, there may be a small number of youth who are open to the department who are being covered by the NHP program that are not in foster care. So there may be a small number of in-home youth in that count. There may be an undercount of behavioral health services if NHP is not the payer. So if the family is receiving services from a third party or from a payer who is not NHP, we may be undercounting behavioral health services. Also, if the behavioral health services were provided by NHP but not within the same quarter that the psychotropic medication was prescribed, we would have to put 2 quarters together to try and determine that. So there is a possibility that we're undercounting behavioral health services. And finally, over or undercounts of concurrent medications. Because the data is received on a quarterly basis, again, there is a possibility that as we put the files together, we may miss or overcount concurrent medications. And next slide. And contact information.
Thank you, Colleen and Leon. That was a great presentation. Actually going to turn it over to Regine to facilitate our question and answer period.
Leon and Colleen, thank you for your very insightful presentation again. So to our audience, we are now going to take questions. You may submit a question online by clicking the Q&A icon located in the floating toolbar at the top of your screen. So our first question is to Colleen and Leon. Is a neighborhood health plan working with DCYF to refine the coding in their data for the youth in foster care?
They are in the process of looking into that. They have not yet committed to provide an indication that the coding will be changed, but they are looking into that because they know that that is important. And they have been very responsive in terms of when we've asked for any modifications.
Thank you, Colleen.
Leon and Colleen, I have a question as well. Colleen, one of the things you talked about were a number of additional questions that were answered by shared data, and you talked about these questions potentially leading to the development of an early warning system. Could you just say a little bit more about that?
Sure. If we can identify factors that predict some of our indicators that we'll be looking at, such as are they too young or concurrent use, then we've done this before where we build into our system that when a child enters foster care and the data is in the RICH's system, if they meet a certain criteria, we code for if they meet a certain criteria, then they would be considered high risk. So we have this for our long-term foster care. What we did was we looked at factors that were associated with youth who are in long-term foster care. And rather than waiting until month 10 to say, okay, they're starting to look like they're in long-term foster care, the characteristics that are associated with being in long-term foster care are identified, and as soon as they enter into our RICH's system, we can identify them as being high-risk long-term foster care. So it may be certain characteristics such as age, removal reason, if they've been previously in foster care, and so if they meet all these different criteria, then they're put on a list that they're at high risk for long-term foster care. And then at the 6-month ARU, the Administrative Review Unit, the reviewer inquires about this youth with the caseworker to see how are things progressing in terms of permanency. And so we were looking at maybe doing something similar with psychotropic medication. As youth come in, if let's say they've been on medication previously, if they've been in foster care a number of times, then they may be at high risk for being concurrent users. So looking at a system along those lines.
Thank you, Colleen. Thank you for your explanation. We have another question from our audience. What is the definition of psychotropic, and does that include antipsychotics?
The definition of psychotropic medication was determined by our child psychiatrist. She was given a list from Neighborhood Health Plan that included medications that they classified as psychotropic medication. And our child psychiatrist went through the list and then determined which medications she agreed with. Most of the medications that NHP had classified as psychotropic medication, she agreed with. I think there might have only been a couple. And yes, antipsychotics are included in psychotropic medication.
Thank you again for your explanation, Colleen. We do have more questions, but we're going to hold that until after our next presenter, which is Ted Williams from Oregon. Dr. Ted Williams, he works for the Oregon State University Drug Use Research and Management Group, which contracts with the Oregon Health Authority to provide clinical services to the Department of Medical Assistance Programs. Prior to completing his pharmacy degree, he worked as a software developer for 9 years. He participates in medical missions through the organization Global Health Outreach. He also volunteers and consults with the House of Angeli, the first long-term transitional housing facility in Oregon for adult victims of human trafficking. Dr. Ted Williams earned his Doctor of Pharmacy from Oregon State University's College of Pharmacy. I'll now turn the presentation over to Dr. Williams.
All right, thanks very much. Let's see, I'm going to get my slideshow going. There we go. Okay. So unlike the last presentation that to really develop and plan and work out the details of their data access plan ahead of time, we went through an evolutionary process, kind of like the pictures here. You can kind of see the evolution of Ted here, some of my good choices and some of my bad choices. I'll refer you to the left side and the bottom right-hand corner for some of those bad choices. We definitely evolved through our process. So what I'm going to do today is walk you through that process. Again, talk briefly about where things were when I started with the program, how we developed which quality measures, answering questions like we just asked about what medications constitute psychotropics. I'll let you know where our program is right now and where we're looking to move ahead to. Also, as questions arise throughout, there are a lot of detailed slides, and if you have questions on a particular slide, do note the slide number in the upper left-hand corner there, and so I can address it specifically. So in Oregon, we have the, whoa, sorry about that, minor technical issues here. Okay, so in Oregon we have the great advantage that we have an integrated data system. So a lot of the cross-platform and cross-agency trouble that I'm sure many states have, we're blessedly insulated from that. And so we have a small data warehouse within the College of Pharmacy where I work that we have even more flexibility with. So we don't need a lot of centralized IT resources to do some of this analysis and data retrievals. So we're very fortunate there. On the downside, we have managed care here. Well, I shouldn't say that's not a downside. Managed care is great. We have coordinated care organizations, which about 80% of Oregon Medicaid members are involved in, but most of the psychotropic medications are covered by fee-for-service. So the coordinated care organizations don't pay for those. They have a delay in when they see those claims, and there's varying levels of sophistication with working with that delayed information. So there's a real fragmentation of care, especially around psychotropics. So we have some real challenges of continuity of care around this issue. So that's one of the themes you're going to see is trying to improve the continuity of care. And again, we did, as we'll see, we have limited access to state IT resources and clinical resources. Alrighty. When I started in June of 2011, we had a very basic evaluation process. So we had some basic age criteria, were they on certain psychotropics. And we classified it appropriate or need more information or a medical director review was required. These were our only 3 stages. So pretty much anything that was really 3 or more psychotropics, we identified as medical director review required. So an individual chart note provider consultation would be appropriate. We quickly found that our 1/4 of an FTE dedicated to conduct those did not have time for the hundreds and sometimes thousands of cases we had that met those criteria. And we had no support staff to try to contact doctors, to try to collect chart notes. So what we had originally envisioned as our process really became unwieldy, impractical. So we needed to do a better job of leveraging the resources we had, like the folks here in this picture. We needed to get a little smarter and accept their limitations. So we rolled our own. We did a lot of automation. We built it all through desktop applications, in particular Microsoft Access. Again, many of you who don't have IT resources or understand the constraints of state IT resources may appreciate that you can do this using simple desktop applications. So it is a possibility. And so that's the process I'm going to walk you through. So when we started out, we really explored a lot of different ideas. This is just a sample of one of the early metric aggregations we came up with. And you can see there's a long list of them. We use this really as a starting point to talk about what were the most important things we needed to deal with. Where did we want to focus our very limited resources? And then these reports generated a lot of questions that this group has also mentioned. What is an appropriate indication? We know the FDA indications are a starting place, but expert opinion is another great resource that sometimes expands or contracts the FDA indications. So we had to work through that on a drug class by drug class basis. We had to determine which medications we felt we would include as psychotropics. Antihistamines are a great example, often used for their sedating powers. Did we want to include those? Which anti-epileptics did we want to include? So we had a lot of issues in working out the particulars. So having this initial draft of the metrics really helped us ask these questions of ourselves and ask the question, who do we need to talk to about these questions? So we, through the great help at CHCS, we got some good answers. We developed a community advisory group from providers from all across the state to help us answer those questions, which were very helpful. We leaned heavily on the HEDIS specifications, which is a national set of definitions for data collection and measurement. And these were really valuable as we spoke with other states and with IT resources within the state, because it gave us a language that everyone understood and was fairly standard. So, and in the end, we ended up with a much condensed example here of the metrics we were looking at. We felt like these were important clinically, that they were easily obtained through our data, and that we felt we could develop programs to drive change. So now we found ourselves at the point where we had this great summary data. We wanted to take the next step of starting to act on it. In Oregon, we do have statutory requirements that for foster children, there's an annual review of their psychotropic therapy. And up to this point, we've been doing those reviews, but more or less in name only. We were meeting the letter of the law, but we weren't really getting at the spirit of the law, because these are kids. These are cute, little, adorable children that need special care, that are in really tough clinical situations. They have real challenges they're facing. And we wanted to do something a little more than just meet the letter of the law. So we took the claims data we had and built a claims-based profile to share with the caseworkers to start these conversations about what does it mean when a child is on 5 or more psychotropics? Why do they need to have this laboratory monitor? So the next slide is an example of that template. Excuse me. And I've included most of this for your reference, but very briefly, in the upper left-hand corner, you'll see that there's some basic patient information. The upper right-hand corner is our screening results. So which of those metrics did this patient meet? We also have a mental health diagnosis history and a prescription history. And so we've included all this, again, to start those conversations with the caseworkers. And we have a fantastic nurse who's working with them now over the last year, is really, again, done just a great job of starting those conversations and talking through these. And this report, very simple report, has really been a great tool for, again, facilitating those conversations. So these are generated every month, and every child is reviewed once a year using these reports. So once we reached this point, we were really excited, but we knew with so many children in CCOs or managed care, we needed to get this information out to the CCOs, and not just for foster children, but for all of our children. So we decided to go with a dashboard, something we had great success at my time at the VA with for driving clinical improvements. So our dashboard, we wanted to combine our summary data, our patient-specific data, and introduce a new piece of a work driver. And what I mean by work driver is something with a clear piece that has clear specific information, a clear and specific action required. And I'll show you what those are. Again, because of limited IT resources, we built this out of Excel. So we took our nice little Access database, built some automation to create an Excel spreadsheet. These are on a schedule. They run automatically every week. No manual manipulation needs to be done. So this is a screenshot of one of our spreadsheets. And you'll see on the left-hand side, there's a column called Metrics right below the color coding. And great, I see a question popping up on the Q&A, but I think I'm going to defer on. I'll keep going as we talk about this. So you'll see our metrics. The provider here is our health plan. We say the numerator, how many cases meet that criteria, the denominator, what's our total population, and on the far right you can see we have the overall Medicaid numbers, so the CCOs can compare their numbers to the rest of Medicaid and see how they compare. On the left-hand side, we use the Excel grouping feature, where if you click on one of these plus marks, it'll expand that section, and then you drill into the detail of each doctor. And so we see all of the cases that make up the 3 or more concurrent psychotropics. There's 20 of them in all care, and we can see which ones are prescribed by which providers and how those numbers compare to Medicaid again with the color coding. And again, these need to be interpreted with care. Just because it's 100% for, say, Dr. J.E. about halfway down the page, he's got 1 of 1. That's not necessarily a prescribing problem, but it starts a conversation to think about what's our overall community standard of practice, and is that where we want it to be. So now let's talk about work drivers, a new piece. So here we have our same metrics going across the top this time, and our patient list along the side. And for each of the columns, we've color-coded it as red if they meet the metric. And you can see any one child which metrics they meet. From a work driver perspective, you can also filter it by clicking on the box where the arrow is, and you can filter it just for the ones that meet that metric. So you can see a shorter list of folks and see what is the overall prevalence. We have another version of this spreadsheet that I didn't include due to time and space that's organized by providers. So you can see for a particular provider how many of their cases or which of their cases meet the criteria. So if appropriate, you can have a one-on-one conversation with that provider, or the CCOs can have a one-on-one conversation with those providers. And here you'll see the blue lettering here actually is a hyperlink, so that when you click on that blue link, it opens up that patient profile we were looking at earlier. So not only can you see if they met the particular metrics, you can get more detailed information about their mental health history and their current prescriptions to see if it really is clinically significant or not. And because I'm a visual person and I love graphs, we provide a ongoing trend of how the CCOs are doing over time for each of these metrics. And we give, there's 4 lines, one for the overall Medicaid rate, one for the CCO, and then 1 line each for the CCO with the lowest rate, and 1 line for the CCO with the highest rate. So CCOs can see where they fall in the range of other CCOs. And again, that doesn't necessarily mean anything, but we hope this provides CCOs an ability that when they do institute a quality initiative, that they already have a built-in tool to see if they're having an impact and to help manage their activities. So, as I mentioned, these reports have those hyperlinks to those individual patient reports. And when we're talking about thousands and tens of thousands, well, not tens of thousands, but thousands of children, the files can get very, very large. And we wanted a way to share this information that was secure for HIPAA reasons and something we could automate and something practical where we weren't trying to send 100 megabyte files every week. So we used Microsoft SharePoint. We did need some central IT sources for this, but it's very scalable. We can have any number of users. Users can log on whenever it's convenient for them to hop on, get the latest version of their dashboard. They can even sign up to get alerts when a new version is updated, which happens every week on schedule. And we're very satisfied with this tool. We've had great uptake with it as well. The CCOs, all of them have asked for access, and I know several of them are really active in developing quality initiatives around this and have had great pointed questions that have helped us improve the tools as we've gone. So the collaboration and innovation has been really great, and we're looking forward to seeing how these initiatives that the CCOs are initiating change the results and drive the results. And our goal here is when we see one CCO's numbers bending in that particular direction, we'll reach back out to them, find out what they're doing and how they're doing it, and then try to share that information across all CCOs, again, to get best in breed out there to everyone to improve our care. At that point, we especially our P&T committee, had lots of questions about, well, who is prescribing these? Is it family physicians? Is it psychiatrists? Is it nurse practitioners? So from there, we developed, using the same information, we just resorted it based on the provider type. So now we can view each of these metrics by the provider type. So I won't get too far into that, but just another level of data we got into. Next piece is something we're doing at the fee-for-service program, not at the CCOs. We wanted to combine some educational materials with these great patient information and these provider profiling for our own quality initiative. So the next few slides are lots of screenshots, lots of small type. I apologize for that, but I just want to give you a sense for where we're going. So this piece, this initiative is on our 3 most concerning prescribing patterns: 5 or more concurrent psychotropics, 2 or more concurrent antipsychotics, or children 5 or under on a psychotropic other than stimulant medication. So we sent out a letter, or we're sending out a fax that explains the policy. We provide this chart that shows 1 bar for the overall Medicaid rate. The second bar is for this provider's prescribing pattern. And then the third bar is for their specialty, so that if I'm a psychiatrist, I know my prescribing pattern is going to be very different from the overall Medicaid rate. I see the sick kid. But in this case, this provider has much higher rates even than their own specialty group, psychiatry and neurology. And we're hoping that providers will know where they fit in the complexity of cases within their specialty, and it might give them reason to think about them. Is my prescribing really appropriate? Am I in line with my peers? Or if they're doing well, give them some bragging rights for the folks down the hall. Because I know this is really rare in Oregon, but providers are fairly competitive folks. Other states may have different issues. The next page, again, this is more for your reference. We provided patient-specific information, so we gave them the name, we gave them the exact drugs they've been taking recently, and then we asked them to tell us what their target indications are, what they're trying to manage with these, as well as a series of questions, not only to collect our own information for policy design, but to help them think about what other options there may be other than polypharmacy. So we're excited. This one's going to roll out in the next few weeks. We'll see what the results are. And another sample here, I'll talk about it very briefly. Another fax campaign for providers. We have a bar chart showing how their prescribing practices compared to their specialty versus overall Medicaid. This is for children who are receiving an antipsychotic but have not received their annual metabolic monitoring. So at the bottom of the page on the left-hand side, you see the recommended metabolic monitoring schedule. On the right-hand side in the upper corner, it's tough to see on this slide, but we have a chart of differential metabolic effects of weight, waist circumference, glucose changes for 5 common antipsychotics, as well as the criteria for metabolic syndrome in children, which is a little different than adults, and so we wanted to share that. And the following page has a list of all of their children that haven't had metabolic monitoring, and we asked them to tell us the status. Has it been done and we just don't have a claim for it? Are they going to schedule it? Is it not necessary? Again, trying to prompt them with specific patients to make changes. So here we've combined the metric reporting, give them a report card, give them some education, and then give them an immediate opportunity to apply that education. So looking forward, we'll keep monitoring these new programs. We're really excited about them. We'll see if we are able to move the needle, which at the end of the day is what it's all about. We continually refine our messages to make them more appropriate and accurate. And continuity of care, as I mentioned, is a real concern for us. We're looking forward to improving that. We're excited about some opportunities in the state for a statewide psychiatric consultation service. And we're hoping to do some on-site education as appropriate. Those are the slides I have, and I'll start entertaining questions. I've already got a list of 3, but I'll just start jumping in here. The first question is, how much did it cost Oregon to develop the dashboard and other automated med monitoring programs? Cost is a good question. I'm a clinical pharmacist. I work with the drug use review program, and we've done this as part of my work. Because I have a slightly different background than many pharmacists, I was able to do some of this development. I don't have a total on the hours. I apologize for that, but this process that I've outlined here took 2 years. The creation of the spreadsheet and the big piece of automating the population of the spreadsheet, that took me about a month. So we're probably, but not a full-time work. So probably about a third of an FTE for a month to work out all the kinks in that process. Someone who was a full-time IT person probably could have banged it out a lot faster than that. I'm a bit out of practice today. So the next piece, are you seeing changes in practice as a result of your data monitoring? So far, we have not in the prescribing patterns. Again, the facts I just showed you, that's scheduled to go out. We haven't seen big changes based on the CCOs getting that data. For metabolic monitoring, we have seen quite a bit of, we saw some really good response the first time we sent out that message a couple of years ago. We got about a third of responses, and about half of those let me step back, sorry. A third of the faxes we sent out, we received responses, and about half of those responses indicated that they had conducted metabolic monitoring based on the fax, or they had scheduled it based on that fax. So from a monitoring piece, again, slam dunk, standard of care stuff, we did see some good impact from that. Changing prescribing patterns, we're still early in the game for that. So the next question I have here is, have you had issues with providers complaining the data is wrong, inaccurate, and not current? That's a great question. For providers specifically, we've only sent out messages on the metabolic monitoring piece, and we have had some questions about that. And we handle that in a couple ways. One, in our messaging, we caveat that this data may not be, it is claims data, and we acknowledge there are delays and incomplete information. And in the response for the metabolic monitoring, we give them a place to check. It's already been done. And to further minimize that, we've also included the date of the last claim we do have. So we show that, hey, we do have something. And that also helps our internal QA. We can check, say, oh, that is only a 6-month flag. Oops, and I apologize here. I just lost my chat list. Okay. So that's a great question about currency and the wrong data. And we also have a manual review process, especially for the 5 or more psychotropics. Again, our biggest hedge against that is that we include all the information we do have, the date, the prescription number, the quantity. And we did have one provider that did complain that, hey, I haven't written an antipsychotic for months for this kid. Well, we responded with, well, here's the date of the prescription with your name on it. And our hope there is that if this may point to antipsychotics that should have been discontinued but aren't. But that's a great challenge. The next question I have is, for states that are just starting down this path, what lessons have you learned that you could share? What would you have wished you had thought of earlier in the process, done differently, did well, etc.? That's a good question. I think that the lesson I learned is to go from, again, June 2011 when I started, to putting our first version of the dashboard online was 2 years. So patience was the thing I wish I'd had more of. But I did really appreciate, once I stepped back and realized it was going to take longer than I had hoped, took a incremental approach. We did a small piece. We ate the elephant one small bite at a time. And that would be my recommendation, as it seemed easier to get stakeholder buy-in, to get administrative buy-in by small incremental steps versus rolling out an entire comprehensive program at once. One, it was easier to secure resources to get approval for. Also, I found it generated quite a bit of excitement. Once there was a taste of it in key stakeholders' mouth, then they rather than questioning or challenging the program, they started advocating for it. So I think that's probably the biggest thing I was interested in. Are copies of the Access and Excel databases available for other states to use or purchase? That's a great question. I don't know about that. Certainly we can share templates that we've used. I'll work with the CHCS team so you can see the templates, say, of our faxes and of the spreadsheets. And I'll check to see if what else we can use. There are some tricky pieces with the data. But that's a great question. I'll get back to the CHCS team with what we can and can't share. But I'm guessing we can get a fair bit of stuff, material.
Thank you, Ted. Thank you for your thoughtful responses to the questions. I just want to give Leon and Colleen an opportunity to answer the last question that was posed to you. For states that are just starting down this path, what lessons have you learned that you could share? And what would you have wished you had thought of earlier in the process? Done differently? What would you have done differently? What would you have done? What did you do well? So Leon and Colleen, do you have any response for that?
I think we'll both kind of weigh in on that because we both experienced similar, but kind of looked at things in also different ways as well. I think one of the things I think that I would recommend is to really be clear about the questions that you want the data to answer. There were some questions that we had thought of after initially meeting with them and setting up the parameters for the data file, and it was much more difficult to have some modifications. Now that said, you can't anticipate every question you're going to have, but I do think it's beneficial to make sure that you have all of your questions that you want answered from the data, as well as the data elements you think will answer it. In part, sometimes we would go over there with data elements we thought would answer our questions, and then because they know their data better, they would identify other data elements that would be better matched to answer those questions. So I think that's something that I would recommend in terms of moving forward.
Thank you, Colleen. Thank you for your response. I'm sorry, Leon, you can go ahead and respond.
I agree with Colleen. Trying to identify what you want to do with the data. I mean, one of the things we had decided was we wanted individual level data. You can always take individual level data and aggregate it, but you can't take aggregate data and go down to an individual level. So I think that's one of the things we did well, was getting the individual data. And as Colleen had mentioned, when you're working with another agency and this may or may not be their priority, even though it's yours, it does take a long time to turn around some of these changes. So just trying to be thoughtful about what information you're asking for to try and get it as close as possible, and then maybe do some test files that you might be able to turn around quickly before you go into a production environment where things get a little more difficult to make changes to.
Thank you, Leon. We have another question for Ted. Do you find that patients on regimens above the safety threshold for longer than 6 months, and are these patients the most difficult?
That's a great question, and we have not looked at it in terms of the most difficult. So what to do with these cases, we're really at the point of we're identifying them, we're trying to raise the awareness of these cases. As far as changing prescribing patterns, we don't have good strategies for that yet. So unfortunately, I don't have much of an answer for that one.
Thank you, Ted.
So this is Kamala again. I just wanted to jump in and synthesize what we've heard. Next slide, please. Great. So I think in summary what we're hearing today is that there are many different paths to data sharing to improve oversight and monitoring of psychotropic medications. What we heard from Rhode Island was a strategy where the state is getting the data from its Medicaid managed care vendor, and as Leon just suggested, it's the state's data, but the vendor has got to prioritize that and provide it to the state, and so that process is being refined. And I think one of the key takeaways is that with any data sharing effort, that process is going to be iterative and it's going to need to be refined. In Oregon, we've got a different scenario where the state is actually providing the data to its system partners, to its coordinated care organizations and to its fee-for-service providers, and giving them data with which they can make different decisions. So they at least have visibility to their own prescribing patterns and what those prescribing patterns look like in the larger context. So in terms of effective strategies, you know, and I said this, I was laughing as Leon and Colleen were talking about being clear about the need for and the use of the data. I think that that's foundational and very important. What do you want to know and why, and how are you going to use that information are, I think, some of the key questions to be asked at the outset of the data sharing journey. A second point, commit to share data that will support partners' goals, and I probably should have put there if appropriate. There's certainly some data that may not be appropriately shared with system partners, but certainly there's some subset of the data that you might be able to come to some agreement around and have the legal folks sign off on that's going to enable you to support each other's health-related goals for that shared population. Next, leveraging existing mandates. We know that in some states there are regulations that support data sharing for individuals for whom various agencies have a shared responsibility, and that certainly would be the ideal, but in every case, every state, that's not the case. In some instances, we may have to have a memorandum of understanding, and this gets to this next point about making data sharing a formal agreement, not an informal type of scenario. And so it may be memorandum of understanding between agencies, contracts with vendors that require data sharing with the state agency that holds that contract. And then finally, understanding and acknowledging the limitations of the data. It's important to know what the data tell you and are able to tell you and what it can't, and that there may be other types of data or other information that needs to be brought to the table in order to have a clear and complete picture of what's going on with this population. So with that, that concludes our formal comments, and I'm going to turn it to Regine to close out today's webinar.
I just want to thank all the speakers today for sharing effective strategies that states can use to enhance their data sharing practices to improve the oversight and monitoring of psychotropic medication use. If there's any questions that we were unable to get to on today's call, we will answer in a summary that will be posted to CHCS's website. The slides and a video archive will be available on our website shortly. An email announcing the posting of these materials will be sent to today's participants as well. Our next webinar in this series will take place during the month of March and will focus on education engagement of providers. More details will be made available in February. We ask that you complete a very brief online evaluation, which will pop up on your screen after this event is finished. Your feedback is very important to us. Finally, we would like to once again thank the Annie E. Casey Foundation for their support of this webinar.
Thank you.